Next, we will learn about the bladder injury. The bladder is an intraperitoneal organ in adults and located deep in the pelvis when not filled, protected by pelvis fascia and muscle, and not susceptible to injury except in the case when pelvic fractures or bladder is filled beyond the pubic to the lower abdomen. The causes of bladder injury, including penetrating injury, are mostly caused by the penetration of sharp objects such as shrapnel and bullets during the war. Closed injuries are divided into injuries caused by direct and indirect violence, such as direct injuries of the lower abdomen and indirect injuries due to pelvic fractures. Laparogenic injury include those caused by cystoscopy, transurethral resection of bladder tumor, and prostate resection. Spontaneous rupture of the bladder occurs in pathological bladder and is caused by bladder tuberculosis and advanced tumors. The bladder injury is clinically manifested by shock, which is often caused by severe pain of pelvic fractures or caused by a massive hemorrhage. Patient may also suffer from dysuria and hematuria as urine flows into the abdominal cavity or around the bladder. After rupture of bladder and patient is unable to urinate or only a small amount of hematuria is discharged, as well as pain as bladder rupture can lead to occur, peritonitis, and severe pain in the lower abdomen or suprapubic or perirectal pain. Local swelling and ecchymosis are also clinical manifestation. In the case of closed injury, patients can often show swelling, hematoma, and ecchymosis. Hyperectomic is caused by peritoneum absorbing the urea from large amount of urine entering the abdominal cavity. Fistula is a type of penetrating injury and often comes along with body surface wound. The leakage of urine from rectum and the vagina may also form the urine fistula. The diagnosis of bladder injury consists of medical history, inquiry, and physical examination. Another examination is catheterization, which is performed by inserting the catheter into the bladder, and if more than 300 ml of clear urine are drainage, the bladder rupture can be basically excluded. After injection of 200 to 300 ml of sterile normal saline through the catheter and suction after a while, if the absorbed amount is reduced or the difference between the amounts in and out is large, the rupture of bladder may be suggested. Bladder injury can also be detected by cystoscopy, X-ray, or CT. The treatment of bladder injury should be determined according to the types and severity of injury, including emergency treatment, positive anti-shock therapy such as infusion and blood transfusion, sedation and analgesia, and early application of broad-spectrum antibiotic to prevent infection. For mild closed bladder injury and injury caused by cystoscopy, conservative treatment is often adopted to avoid surgery. In terms of surgical treatment, the general principles include complete urinary diversion, adequate drainage of extravasated urine, and repair of bladder wall defects. The last step is to deal with the complications of bladder injury. For example, the pelvic effusion and abscess can be aspired under the guidance of ultrasound and treated with broad-spectrum antibiotic at early stage, and the abscess and peritonitis in the abdominal cavity can be treated with adequate antibiotics to control infection and drain the abscess as soon as possible. The last one is the urethral injury. Urethral injury is the most common injury in the urinary system, often found in young men and can be divided into penetrating, closed, and iatrogenic injury. Penetrating injury is often seen during war and caused by sharp objects. Closed injury can be divided into contusion or laceration. Iatrogenic injury refers to injury from violent actions during improper operation of instrumental in the urethral cavity. Closed injury caused by external violence is the most common. The male urethra is divided into interior and posterior parts by urogenital diaphragm. The anterior urethra, including the bulbous part and the penis, and the posterior, including the prostate and the membrane part. The bulbous and membrane injuries are the most common. The injury of interior is more common than that of the posterior part, often found on the bulbous part, and mostly caused by closed injury of the perineum due to straddling. When the urethral bulb is damaged, the blood and urine will firstly penetrate into the superficial perineal space surrounded by perineal fascia, causing the scrotum swelling. If the injury continues to develop, it may spread along the perineal fascia and make perineum and penis swelling, and further spread upward to abdominal wall along the deep layer of superfascia, but confined to the groin and deltoid ligament. After the penis of urethra is ruptured, if the deep fascia is complete, urinary extravasation and hematoma is trapped into deep fascia of the penis, manifested by penis swelling. In case of simultaneous rupture of the deep fascia, the distribution of the urinary extravasation would be the same as of the urethral bulb injury. Anterior urethral injury is clinically manifested by urethral hemorrhage, local hematoma, and eschimosis, pain, dysuria, and urinary extravasation, and can be diagnosed by medical history, physical examination, diagnostic, catheterization, and X-ray. The injury is treated with emergency treatment such as anti-shock therapy and preventive antibiotic. Urethral contusion often requires no special treatment, and the catheter can be placed when necessary to drain the urine for a week. If the case of urethral rupture, the catheter can be retained for drainage for more than 2 weeks, and if the catheterization fails, it is necessary to perform debridement and hemostasis and suture the urethral rupture. In case of urethral fracture, urethral end-to-end anastomosis should be performed directly, and urinary catheter should be retained for 2 to 3 weeks. The posterior urethral injury is commonly seen in traffic accidents, followed by accidents such as house collapse, with more than 90% of patients suffering pelvic fractures. A series of musculoskeletal changes resulting from pelvic fractures eventually lead to tear or rupture of the membranous urethra. It is clinically manifested by hemorrhagical shock caused by excessive bleeding. Hematuria and urethral hemorrhage are also manifestations. Pain in the lower abdomen or tenderness may occur. Patient may also suffer from dysuria, urinary extravasation, or hematoma. The posterior urethral injury can also be diagnosed by medical history, inquiry, physical examination, and X-ray and retrograde urethroplasty. The treatment includes systematic treatment. The patient with fracture needs to lie down and cannot be moved at will to prevent aggravation of the injury. For the patient with mild symptoms, catheter can be attempted to place and keep for 2 weeks of drainage. Otherwise, surgery, primarily urethral realignment and reduction, should be performed immediately. As for the treatment of complications, in case of urethral structure, urethral dilatation needs to be performed on a regular basis and surgical incision is required for severe case. For the case complicated with rectal injury, neoplasty should be performed as early as possible. In case of concurrent urinary rectal fistula, neoplasty should be performed 3 to 6 months later.